Hello everyone and good morning. I'm Amit from Nalashaa, and I take care of the healthcare division's growth at Nalashaa, and I'm here to facilitate a very productive session on MU3. If any one of you is not able to hear us out, just ping a message that's on the right hand side of your screen. There is a chat window and we will respond to you. We'll be able to help you out with that. All right. So today we would be touching upon MU3, its avatar after MACRA, the details about what needs to be done for MU3 and how much time and effort you might need to spend on it. We'll try to wrap it in about 45 minutes, which would be followed by a 15 minutes Q&A session where we would be taking questions from the audience. During this session, if you have a question, please post it in the questions pane on your GTM window to your right. During the Q&A session, if you'd like to ask a question, just click on the raise your hand icon, again on your right hand side, and we will unmute you. In order to cut down on the unintended noise, we have muted all the participants except the presenter. If you want to add something during the session, during the Q&A session, please just raise your hand. All right. During the week of Jan 12th, Andy Slavitt left a lot of people in our world puzzled. However, this was perceived by many a bit out of context. We've been following up with the government regulations for quite a bit and are happy to share some of that information with you. Now, some of you may already be up to speed on this. Please bear with us while we set some context for the rest of the folks. Now, after the social media updates by Andy on Jan 12th, the weeks that followed, it became clear that meaningful use will live, though as part of a bigger picture. As the government attempts to motivate providers to embrace alternative payment models, MIPS under MACRA aims to make this transition a little gradual. The objectives essentially remain the same, and that is to improve quality, leverage technology, consume fewer resources to deliver same or better quality of care, and improve at what you currently do. The current slide depicts the areas that we are going to cover in this particular session. This would include why we should take MU3 seriously, what MU3 is all about, what are different things that have changed in this version of meaningful use, and what we need to do as EHR vendors to comply to those requirements. Also, we have included a few slides on the amount of time you might need to spend in order to achieve that. All right. Now, the current slide is a depiction of what MACRA is all about and how meaningful use is going to survive from here now. Now, the timeline for MIPS is set to be 2019, but who knows, when actually it will get started. So that said, meaningful use as we know it will still live as part of MIPS. As you can see on the current slide, MIPS would have 4 different categories or variables with different sets of weightages, and meaningful use happen to be a significant one of those with 25% of weightage. What we have shown here is the constituents of MIPS, and as you can see, meaningful use will demand some bit of seriousness from all EHR vendors if they would like their providers to stick with them. So for those of you who were not sure whether to take meaningful use seriously or not, the answer is yes, you should. Now, that said, I'll leave you with Anuj, who's going to talk about the nuts and bolts of MU3 and help you comprehend it in its entirety. We hope this session proves to be a wise investment of the next 60 minutes from you. Anuj, over to you.
Thank you, Amit. Are you able to hear me?
Yes, we can, Anuj. Please go ahead.
Okay. So, Amit, would you like to make me the presenter, or you would like to drive the slides?
I'll just make you the presenter. Just give me a minute. Yeah.
Good morning, everyone. This is Anuj. I hope everybody is able to see my slide. And Amit, you can confirm that.
Yes, Anuj. Please go ahead.
Okay. So, hi, my name is Anuj, and I work as a healthcare specialist with the Nalashaa Solutions. We have been working on meaningful use, stage 1, stage 2, and now doing the analysis of the meaningful stage 3 requirements and helping our clients to get up to speed to meaningful stage 3. So I will take on the slides from here. We'll start with MU3 focus areas. All of us would have known about the focus areas which we would have accomplished or is in the process of accomplishing, the MU1 and the MU2 focus areas. With MU3, the focus of areas, you can read about it. There are coordination of care, patient engagement, population health security, and health information exchange, which somehow looks identical to the sets which we would have seen before. But the difference here in MU3 is that more than 60% of the criteria here are demanding interoperability and the distributed systems or different systems to be working in conjunction with the help of the interoperability. Especially being the health information exchange, where we would be required to develop, an EHR would be required to expose API where a connected, well-authenticated and registered EHR talking to the EHR, another EHR API, is able to request the data, get the patients, and able to also request the data. Till now, it was on to the discretion of an EHR to always send the data automatically when a transition of care document happens. But now, another EHR, which is on the receiving side of the transition of care patient, can actually request the data. So as an EHR, there are 3 measures or 3 criteria which are in meaningful use stage 3 requirements, which demand that an EHR should be able to expose an API and allow the information to be fetched through an API interface from the EHR. So, and we will talk about other aspects of interoperability and other things which are addition to MU stage 3 as we go deeper into it. On the MU3 criteria, we have done a quick analysis of what has changed, what remains unchanged, and what is absolutely new. So as per our analysis, there are, if I'm looking at the ambulatory settings here, there's about 50% of the criterias, or above 50% of the criteria, I will say, which are either new, revised, or minimally revised. So which means that there is not going to be just an additional development over the current work which has been done as part of the meaningful stage 2 requirements in your EHRs, but also much of the rework has to be done, or maybe a redesign has to be done based on the revised requirements which MU3 has posed. So we are seeing that there are almost 12% new criteria. So ONC has been not adding stuffs too much, but the revision of the criteria is material here, which is almost going to around 36%. The next question we would like to answer is, this 2016, and most of you would know that meaningful use stage 3 is mandated from 2018. So why do I need to worry about it now? Well, I think we have learned few lessons from the MU stage 1 and 2, where many of us were not the early starters and went towards the later phase of it, which led into some of the implementations difficulties which almost most of the EHR providers faced. But apart from that, with meaningful stage 3, as interoperability becomes the driving point with more than 60% of the criteria demanding interoperability, it is important for you to test integration with the with other EHRs or the third-party systems, and also to come to speed to those system demands when they become meaningful stage 3 compliant. So it is always good to begin with it now and start and even get certified to MU stage 3, because optionally you can report MU stage 3 in 2017 as well, and from 2018 everybody should be on MU stage 3. So that will help you and your providers to come up to the speed with respect to the training and the technology upgrades. Now we'll go into the specifics of what has been added or what has been revised in the meaningful use stage 3 requirements. We will not touch each and every minor requirements as such, because that would have been too much for a 45-minute session. So we have kept it very precise, and we have just emphasized on the criteria where we see that there may be a significant usability change on the EHR or a significant code-based change to your EHR. So we'll start with the capturing of information. Well, most of us have seen a lot of changes in the demographics data with both stage 1 and stage 2, where we have to capture additional information regarding the smoking statuses, the race, the ethnicity, and all those things which came part of the stage 1 and the stage 2 requirements. With stage 3, there are more additions to it, and one of the important addition is the capturing of the sexual orientation and the gender identity of the patient, which especially in the behavioral health and even in the clinical health sciences have proved is a very beneficial set of data to get. So that becomes a part of your the patient's demographic profile, and it needs to be even exchanged with whatever confidentiality it is, and it has to be codified with the latest NOMED standards, which will be released in 2016, the updated standards for these codes. Additionally, we also have to be sensitive about the point that some patients may be okay to answer such questions and some patients may not be. So how to actually bring it into your system in a demographics pages, which is mostly on an information capture side, or bringing it through an assessment questions and capturing that information, or if you have patient portals attached to your EHR, asking your patients through an updated profile or while creation of a profile, such questions can be incorporated into EHR directly or indirectly. There are other minor changes to the demographic section as well regarding the occupation and the method of communication on the email, telephone, and letter. Many of you are already doing that as part of the demographic sections, and the disability status. Another important point which has been added is the ability to record and access and even change a list of patients' implantable devices and basically capture the unique device identifier, as we say UDIs, for these devices, and keep a list for every patient, so that if you're going to a patient's profile, you're able to see, just like you're able to see the diagnoses and the problems and the allergies and medications for that patient, you're also able to see all the implantable devices. Now, it's just not a list of implantable devices. There are questions around how did this implantable devices list actually gets into the EHR. There can be a barcode integration if the EHR is to be used at the point of capturing, or there can be other implementations from an API to be able to capture this information into the EHR. Apart from that, this also means that A minimal data set needs to be captured based on UDI. So like the machine model number, the name, what exactly is that machine, and what are the things which a patient should know with respect to the specific education regarding the device which is implanted. So that said, the use of other standards like the info button standard for the specific educations, those also come into the play here, and we see it as a list with a specific info button which is bringing in the information from the FDI, UDI database to give the specific education for the patient around it. Other than that, there are other requirements around ability to receive a document directly from the patient, maybe via direct, and ability to receive it electronically and then tag that document as one of the health information document for the patient as a birth plan, or ability to be tagging a clinical document as an advanced directive, and to store that as part of the patient profile, so we can see all the patient's documents in one place and should be able to view them or record them easily in the EHR. So that's about the information which is required on the changes on the demographic section. We'll move to the CCDA section. Well, this starts the interoperability, and we will explain various other stuffs which are the constituents of interoperability here. But the major driving force of the interoperability changes or the additions in the MU stage 3 are by the virtue of the changes in the CCDA standard. So CCDA standard has upgraded from CCDA 1.1 to 2.1, and Meaningful Use Stage 3 has adopted it as part of creating the new CCDAs from an EHR should be now on the new CCDA 2.1 standard, which is more constrained, has more templates to it, and is more explicit about few things which it was not so explicit about in the CCDA 1.1 standard. There is apart from just to be able to create a CCDA 2.1 standard, an EHR should be able to absorb or consume a CCDA 1.1 document which was part of our MU stage 2 implementation. So it should be still able to read and incorporate data from and receive data from such documents, but the new document should be complied with the CCDA 2.1 standard, and ONC or while the testing or the certification testing, the NEHR will be trusted on both the sender's side of it and the receiving side of it in terms of receiving both 2.1 and 1.1, and in terms of sending 2.1 documents or creating 2.1 documents outbound. Apart from that, another important update, as I explained as part of the health information exchange focus area, is the APIs which has to be exposed on the EHR so that a patient data can be queried based on a patient ID, or with the patient matching records, a set of patient data can be retrieved by a third party. And when a specific patient from that set of data is located, the information or the transition of care or the clinical summary for that patient can be fetched based on the explicit patient which has been located out of the set of patients received from the patient matching request. So there are a series of requests and responses which will be tested, and an EHR should not be just able to send in a document by itself, but the concept is to also to be able to request at real time for a third party from an EHR the data on the assumption that all the security, authentication, and the registrations are in place. The third part to the CCDA is the ability to detect errors. We have been creating CCDAs, sending it to the third parties, and many of us would have seen the real-time scenarios where most of the CCDAs either get rejected and nobody knows what is happening to them. Somebody has to manually look into it and see what's the problem, what is not reported, why the CCDA is invalid. So that part of the problem is also addressed here, and we'll have to create, as part of the creational side of CCDAs, an EHR should be able to also validate and locate the errors in the CCDA, and should also be able to um, um, to explicitly state where those errors are. On the receiving side, as well as a validating tool, when you receive a CCDA, you should be able to view the errors explicitly without manually going into the document, which was one of the challenge from the CCDA stage, from the meaningful stage 1 and stage 2. The confidentiality was ignored as part of the releasing the CCDA document out of the EHR in MU stage 1 and stage 2. ONC has addressed it now in meaningful use stage 3, and this means that the document level tagging is now included as part of the criteria, where an EHR or a patient or a provider will be able to tag a document on the document level in the CCDA as confidential. Now, CCDA actually supports a multi-level confidentiality configurations. That means you can also configure the sections, let's say a diagnosis section or a problem section or a medication section, or even a certain medication, which are called as entries in CCDA, to be confidential. However, as a starting point, the stage 3 has just kept as part of the DS4P standard just to be ability to at least tag the header level, that is the document itself, as confidential. And there are responsibilities both on the sender side when you create a confidential document, and there are responsibilities on the receiving side as well, because if you receive a confidential document, then what should you do with it? So there are two criteria, one for the sender and one for the receiver, which has been added in the stage 3 requirements. On the receiver side, once you're receiving the confidential document, there should be some way to do a separation of confidential documents from non-confidential documents, and then an ability to at least provide a workflow or a signed document to be able to release information or incorporate the data from confidential documents. So all of those information will be part of the is part of the DS4P standard, which is already in place and must be implemented to support confidentiality in CCDAs. Apart from that, as part of incorporation of data, it is also necessary to be able to query on a basis of dates the specific information from the CCDA. Another important addition to the CCDA is the document. The CCDA 2.1 document now supports care plan documents, which means there are additional sections for goals, additional sections for health concerns, assessment sections, and plan of treatment. The plan of treatment section we all are aware about. It was also a part of the CCDA 2.1 standard and was named as plan of care, which has now become plan of treatment. So the plan of care or the plan of treatment section remains as part of CCDA as it remained in the previous stage 2 as well, and many of the EHRs who are complied with stage 2 will be already showing that. But apart from that, the care plan data has to be structured in a CCDA, in a care plan document, with a new template which is supporting the goals, the interventions, the objectives, and the health concerns section separately. So this would require, for the EHRs where the information were not in a structured format, the goals were not and objectives were not coded in SNOMEDs or the respective code systems you might follow for it, will need to be followed to be able to create care plan documents and exchange such documents. So those are the several changes on the CCDA, and many of you would have noticed that this would either require adding the current set of the functionalities to your current design of the CCDA, but will also change the template of your CCDA because the section is changed. But just not that, the pre-existing template of CCDA 1.1 is also has to be complied with, so both should remain. We don't know if the EHRs would have made or added the flexibility or would have foreseen that multiple templates of CCDA would be required to be complied with in the later stages of meaningful use, but that's where ONC has put them onto, and they will have to change their design to support multiple CCDAs or to ability to choose which standard of the CCDA they would like to receive, and even work on those specific 2014 edition or 2015 version of the CCDA. The other important changes was on CQMs. I would not say it as a change because many of you would have done a part of it as part of stage 2, but it was really not necessary and a mandatory criteria, and that is the import function. So everybody would have seen in stage 2 that we would have we had an import the patient data from the QRDA Cat1 files, and that was the automatic import which an EHR must support. But that was optional in nature, and many of us went with putting the data in the system and then running the QRDA Cat1s and Cat3 or reporting ECQMs based on that. However, now there should be an import function which should be built in the EHR as a mandatory criteria for stage 3, where whatever QRDA Cat1 files will be provided needs to be imported automatically into the EHR, and then on top of that various reporting can be done, and various Cat3 files are the numerator and the denominator where we report those files needs to be created on the basis of the date selection or the reporting period selection. Other than that, they have also explicitly mentioned what remains as mandatory part of QRDA to make the data in the QRDA looks, on the sanity wise should be good, and that is the provider TIN NPI type, the practice site address, the insurance, the age and gender, race and ethnicity, and the reporting of the problems or the codes specifically. So these were also the good to do things in the QRDA, but has been explicitly called out in CQMs that these will be looked at. So apart from that, another note which has been made in the stage 3 requirements is that minimum human or manual intervention or developer intervention is required to fetch QRDA Cat1 and Cat3 files. That means previously many of us were offline bringing up the generated ECQMs files, which has to be now supported online. So ONC has made it clear that as part of the testing they would not allow sending the files offline, but ability to see and generate and view and download those Cat1 files right from the EHR without any developer intervention. So that's about some of the changes which are part of the clinical quality measures. The criterias or the measure or MQFs, they remain the same. There are not changes on that, just the version might increase from V3 to V4. On the automated measure analysis side, this is the dashboard side of showing to the provider what all measures and criteria they have already complied with. Many of us would have known that in stage 1 and even in the 2014 stage 2 we had as good as 18 criteria of the dashboard, which has been substantially reduced to 10 criteria in stage 2 2015 edition. And with stage 3 these will be further reduced to 8 core sections as well. So that's another point why you should move to MU stage 3, because then providers need not worry about the other 6 and 8 criteria which they might be unnecessary reporting if your EHR is still on stage 1 or on stage 2, 2014 edition. And that also means that the logic of generating the dashboard should be as dynamic as possible, because with every, just not with every stage, but even with every addition of a stage, the number of criterias on the dashboards are being changed. So the EHR should be able to do that change either automatically or with minimum development efforts. Apart from that, on the public health agencies, we have seen the antimicrobial use and the resistance reporting. So especially for the inpatient settings, they can now report these HAIs in the CCDA 2.1 standard, and can also report the denominators and numerators accordingly. On the electronic case reporting, to report vitals especially, and to report any side effects of immunizations or reactions from immunizations, I would say, the EHRs will now have the capability to even send the CCDAs and put that information in CCDAs and send it to public health agencies to do the state reporting on various parameters. And they will receive a URL on the basis of that, and on the basis of their submission, and that will be implemented once the state starts accepting CCDAs. Another important thing is the participation in the national healthcare surveys. As the CCDA is becoming more important as part of the meaningful stage 3, the other uses or the benefits of it is that providers will be able to automatically participate in the national healthcare surveys, and they will be able to generate the data which has to be submitted for the national healthcare surveys in the form of CCDAs, and that means it makes the life of CDC easy. So they get all the automated data from various providers. There's more sample data available, and the healthcare surveys makes more sense, and the analysis of that can be done electronically rather than receiving the surveys in the manual forms. On the immunization registries, still the syndromic surveillance and the immunization registries are still part of the stage 3 requirements as part of the stage 2. Out of the 4 or 5 public health reporting, we have to just meet 2 mandatory criteria out of the 5. So you can choose immunization and the syndromic surveillance if that had been a choice earlier with meaningful stage 2 and not do the national healthcare surveys. Do you have the capability to do that, because CCDAs can be generated from every EHR after they are done with stage 2 or stage 3. But the only changes in these things are merely technical. So a previous HL immunization message which you would have created as part of the stage 2 might not directly be understood, will be retested with the revised version of the IG of immunization. That means the NIST will have a revised tool and the use cases create for just for the changes which has been done as part of the immunization IG, and you will have to recertify to the immunizations and the syndromic surveillance criteria, because the inherent standard or the reference guide has been updated. Apart from that, the code systems like SNOMEDs, LOINCs, and all of those, needless to say, should be on the latest editions, which is the 2015 edition, as on date on 2016. There are some revised measures. We have talked about the updated coding standards, especially the SNOMED codes, and the codes around the race and ethnicity has to be with respect to the latest changes which has been done in the code system. Other than that, ability to report the e-prescriptions in the structured SIG format. Many of us do the e-prescriptions from third-party vendors like Dr. First, so on, and those should facilitate that automatically. On the direct project, we have an addition of the Edge protocol support that needs to be taken care of with respect to the certification, which we have done already as part of the stage 2. If your EHR is stage 2 certified, the Edge protocol is another variable where a recertification would be required for the direct. The SNOMED CT updates to the problem list for the new diagnosis code, new smoking status code should be also be available in the EHR. On the security, most of the things remain the same as they are also taken from the HIPAA guidelines. Few of the things have been upgraded. The encryption algorithm, the hashing algorithm has been upgraded from SHA-1 to SHA-2. On the audit side, everything remains the same. We have been already doing as part of the audit report criteria as in stage 2. The additional thing which has been added and will be retested is on even auditing the administrator side of or the user management side, where if the privileges are changes for a provider or a provider role change to NP or an NP has been changed to RN or clinician or whatever privileges change in the system, those also needs to be audited so that the accessibility of a user account which is changing with those privileges can be also audited. Apart from that, the emergency access events, which is also a criteria, will also need the audit to happen as part of the stage 3 requirements. For the accessibility, whoever has the accessibility technology criteria and is certifying to it will have to have a text-to-speech conversion tool through the Dragon or whatever you might be using should demonstrate the capability, but this is an optional criteria. On the clinical decision support side, everything remains the same. Your design for stage 2 is also good for stage 3, and just that the reference therapeutic information will now just not in an uploaded document, which many of the EHRs were doing, but should be facilitated with the help of an info button standard. So that's an addition to this criteria. So these are the specifics of the changes in the stage 3, and we have not spoken about very minimal things which has changed here and there, but we have tried to speak about the main changes which are going to be a part of stage 3 and would impact an EHR from the development and the testing perspective. I think that's ends it from me. I will give it to Amit.
All right, thanks Anuj. So I'll quickly get started with this. When we started looking for how much time it would take for an EHR vendor to implement all the MU3 requirements, the only frame of reference that we could find which was publicly available was the Office of Federal Register (OFR) site, which basically gives you the complete trail of all the MU3 measures, what we commented on it, and at the same time it gives the estimates that they came up with that they thought the time that EHR vendors would need to implement MU3 measures. They gave two sets of estimates. One was a conservative estimate, 4,308 man days, which looks huge, and they had an aggressive estimate of 2,800. So we looked at these two numbers and we thought they were just ridiculous. So we went ahead and we did our exercise, and we found that based on our set of assumptions, we came to a figure of about 588 man days, which, yes, we haven't implemented MU3 so far. We haven't finished that implementation anywhere, so there is no way for us to validate it. But we tried to stay as close to the assumptions we made during MU2 as possible. And the last time we did this exercise for MU2, our numbers were fairly close to that. So we would like to see if we are close enough to this real number for MU3 as well. Now, the pie charts below show, based on our estimates and assumptions, the amount of time that you might need to spend in every stage of SDLC. Also on the right-hand side are the areas or categories where you might need to spend most of the time. So as we said earlier, health information exchange has been the focal point of all the meaningful use reforms. So about 30% of your effort and energies would be going into information exchange related areas. Another important area would be quality, safety related measures, and followed by that would be population health. So public health reporting, CQMs, health interoperability. So all these are going to be the key areas where you would spend most of your time and energy. Now, this is a representation of the same numbers, but from a different viewpoint. This shows how much time you might end up spending, that is on a percentage basis, as a percentage of the 588 man days, close to 600 man days estimate that we came up with. Now, if you take a look at this, this tells us that almost half of the effort that you will need to do is likely going to be on the criteria that are revised, which might mean that you may have to modify your existing code. That might prove to be tricky because you may end up adding some new features or modifying it and shaking up some things that already are working fine. So, the ones that are new, we believe those should be straightforward because they might be fairly compartmentalized or disconnected from the rest of the code, especially from a testing perspective. For the revised measures, you might need to do a lot of regression when you go ahead with the implementation. Now, talking about the timeline, what would be a good time to start? So there is no one answer to that. It entirely depends on your particular product and the kind of customers that you have. Now, given that it is possible that some of the providers can choose to report on MU3 in 2017, just because they will have to report it only for a smaller, that is 90-day period, it is possible that some of them may come to you asking if the MU3 version of the software is ready. Other than those, for those who want to do it in 2018 for the entire calendar year, you might have still some time left. But if some of your providers ask for it, depending on how urgent their need sounds, you might want to satisfy those, and which would mean you would have to be ready somewhere by around 2017 beginning. So that's one. Another one is your partners with whom you operate. For example, if you are a patient portal provider and you partner with an EHR that chooses to go to MU3 early on, then you might have a tricky situation at hand because they cannot go alone to their providers with MU3 version, because the moment they send, they toss over a CCDA 2.1 to you, for example, you won't be able to use it in the manner you should be using it. So that could be another consideration. So here we have outlined some of the things that you might need to think about before deciding when you want to start your efforts. So early adopters, yes, that would be a consideration. You would need to give your providers enough time to train their staff because they also won't be able to do that at a short notice, so they need to have sufficient time. A lot of things might change, a lot of workflows might change, so they might need time to adjust to those. So here in the current slide, we have estimated a duration, which may or may not be accurate depending on the customer base you service, but these are just indicative numbers to help you visualize how much time in total you might need. Upgrades, it's going to be easier for those of you who are on cloud, but for those who are on an on-premise version, have a huge customer base, you may not want to have the upgrades overnight because it might turn out to be a support nightmare. If you choose to go in a phased manner, then you would need some time to bunch them together and then move them to the next version, bunch them, take the next bunch, move them to the next phase, that is MU3, and so on. Then certification would also be a key consideration, because those of you who start early, for them, you might get time slots that you are looking for from Drummond or ICSA or whoever it is you choose to go for certification. The more you delay it, the unlikelier it becomes to get the required spot. So you might have to have to spend a lot of time doing the paperwork, understanding the process for certification, preparing for the site visits, and so on. So based on all those estimates, and again, this is just an indicative figure, there might be a good 1.5 year duration for this entire for all these steps. So this would be of consideration, definitely. Now, as I said, it remains to be seen whether our estimate of close to 600 man days would be right at the bullseye or not. But in the past, we have done these estimates for MU2, and we were fairly accurate. So we have a reason to believe that we would be accurate this time as well. That's it for from our side for most of the functional stuff, and we would love to hear post this webinar. We would love to hear your feedback about how relevant or useful you found it. If there are any follow-up questions that you may have, we would love to answer those. And also, if you would like a complimentary assessment of your system to understand what would be the impact of MU3 on your particular system, we would be glad to do a high-level assessment of it and tell you what are the areas where you might be impacted and how much time it might take for you. So with that, we conclude the presentation bit, and now we open the floor for Q&A. May I request the presenter to unmute or yeah, we'll unmute the participants. Whoever raises hands, we will just have those conversations one by one. So if you guys have any questions, please go ahead, click on the raise your hand button. Yes, Margaret, we would make it available. Give us a couple of days of time, and we should be able to make it available. If if there is a way for us to share that, other than that, we would find it and send it across to you. If you guys are unable to find the icon that you need to use to ask your questions, you can also post those in the chat window on GTM page. We can pick it up from there and repeat it for the rest of the audience. Okay, so we got a question from one of our participants, and the question is, are the certification bodies ready with the test procedures for MU3 criteria? So, Anuj, Vijaya, any one of you like to handle that question?
Yes, we did discuss with the certification bodies, and they are ready. They'll be ready by next few months. So we are hoping by May or June they'll be ready, and we can get the test procedures also ready with it.
So just to add to Vijaya's point, some part of it on the 2000, because some part of it is also part of the 2015 revised edition criteria, like the updates to the immunization IG and the updates to the syndromic surveillance IGs. Those are already available as in the NIST test website. However, the maturity of the CCDA test tool, the validation logic, and all those things are still not in place. And the certification doors will open in 2017. So we are assuming that everything should be ready by end of 2016 with respect to facilitating the test.
We got another question from one of the attendees, Anuj. I think this also can be handled by you. The question is, what is the basis for the estimate that we have arrived at, and if you could mention some of the assumptions, broad assumptions that you have made for that number.
Okay, so on calculating the estimates, what we have done here is we have taken each and every criteria from the MU stage 3. We have rated them on a complexity level of simple, medium, high, and very high, and we have done a broad estimate on each criteria based on the complexity level. That is the basis of our numbers, how the numbers have been reached. And the second, but the assumptions.
A question I asked me. Why are we not looking at that?
Amit, can you please mute yourself? I'm sorry. So apart from that, the assumptions to our numbers are that first of all you are already on stage 2, and while you test for or go for certification for MU stage 3, you are on the MU stage 2 2015 edition. So the starting point of these estimates are from there. If if you're not still MU stage 2, in the process of being MU stage 2, and will be with MU stage 2 once we start with MU stage 3, estimates still remain true. But if we are starting with MU stage 2 criteria, we have just the certification has been done on a modular EHR and not on all the measures, some of which have turned mandatory. Then those are some of the assumptions which we have not taken in and must be added to the current estimates.
Okay, there is another one, Anuj. I think this was one of the slides that you presented today. The question is, on one of the slides you mentioned minimum common clinical data set along with patient matching information needs to be made available in real time as CDA documents through an API. Could you please elaborate this?
Yes.
Because I think some of the people couldn't really.
This is something which is the most challenging part of the implementation here, because here every EHR is now opening a gate or through an API to be able to query the data from it and to able to be getting a response from based on the request they receive. So that said, the patient matching information, there is a common clinical data set which has been published as part of the stage 3 Federal Register, which ONC has published, which includes first name, last name, middle name, suffix, patient address, phone number, and the sex of the patient as one of the main criteria on which the patient matching logic would work. Which means that just like we have been querying the systems from an HL7 point of view, many of you would have done those integrations or seen those integrations, or might be happening in your EHR, which you must be aware about. The same kind of integrations will now needs to be done on the CDA side, where your system, which if the EHR is on a web platform, or even if it is not on web platform, will expose a way of consuming the APIs, especially through web services or so on, or the related technologies, where somebody can send a request with the set of patient matching information and a revised set with all the patients matching with it, with their patient matching information, will be sent back. On the basis of that, a patient ID will also be sent back as part of the initial request, and then the requester makes another call with that patient ID to get the clinical and the related dates and the other things of what kind of document he wants to query or what kind of information he wants to query, and with the explicit patient ID in the flavor of the EHR, which is supposed to send the response, an exact patient will be data will be located. So there are series of API methods which will need to be exposed, and the consumer will be consuming those, and the basis of the certification test will also be using the tools like SOAP UI and so on. The endpoints of your API will be sent the data with, and the proctor will be looking at the response and validating it from there. I hope that answers your question. If I'm missing anything or anything is not clear, please feel free to put a follow-up question.
All right. Thanks a lot for your time, everyone, and we would, get back to you over an email sometime later this week or next week to know the feedback about this session that we had. If you have any follow-up questions after this session, please feel free to respond to the email ID from which you got the invitation for the webinar, and we will be glad to help you out with whatever questions you may have. Right? Thank you for your time very much, and have a good day.